So at this year's AACR, on behalf of my colleagues, Dr. Cho and the team presented the results of Amivantamab used as monotherapy in patients with wild-type non-small cell lung cancer after cancer progression on chemotherapy and immunotherapy or anti-PD-1 or PD-L1 treatment. And, this was very interesting for us. Up until now, Amivantamab, which is a bispecific antibody targeting EGFR-MET with immune cell activating properties, was really studied in oncogene-addicted tumors, and of course, as you know, is approved for use in patients with EGFR exon 20 insertion mutant disease, both in first line with chemotherapy and then also in second line as a single agent post-chemo. So we were very excited about this to see if this worked, really based on targeting protein. We had two cohorts, patients with adenocarcinoma, which was wild type, and those with squamous, and patients were all pretty heavily pretreated. We tested 41 patients with adenocarcinoma. In the whole cohort, we saw a response rate of 70%, but we further refined the genomic classification of these patients using liquid biopsy or plasma testing. And what we found was that patients who had KRAS or HER2 mutations did not have any activity with Amivantamab, and we know that often these patients have tumors that signal through pathways that can be distinct from EGFR and MET. But in the patients that did not have KRAS and HER2 alterations, the response rate was actually 20%. A median duration of response about 4 months in the whole group, and at least one patient has had an ongoing response after 6 months. In patients with squamous carcinoma, we were very surprised. It was a smaller number of patients, 14 altogether, but the overall response rate was 21%. No patient had progressed as their primary response, and at least 2 patients now have ongoing responses beyond 6 months with a median progression-free survival of 4 months. So, we were really delighted to see that Amivantamab, even in non-addicted lung cancer, in particular treatment refractory adenocarcinoma and squamous cancer, had activity. There were no new safety signals, and in particular, in those patients with adenocarcinoma who did not have KRAS or HER2-driven tumors, the response rate was higher, up to about 20%.